this afternoon we're graduating towards looking at policies, the enabling environment. And so to help set the scene and to give way to the Q&A session that will be coming up against, I have a set of 4 speakers. So to my left is Kiran, who will be speaking to us about the India experience, and he comes all the way from India. And so welcome, Kiran. I was going to try and pronounce his last name, but he graciously encouraged me to avoid the tongue-twister situations. And then I have Dr. Mahesh, who will be giving us a presentation based on the Malaysia experience. And then Dr. Joyce, nice to see you. We actually met 2 months ago on the digital health governance, which I'll talk about briefly. And then last we have Nat, a dear colleague and friend of mine from WHO. So I'll be a facilitator, Derek Munene. I'm head of capacity building and collaboration at the World Health Organization, Department of Digital Health and Innovation, into which we've been promoting the global initiative of digital health. That said, we'll get straight into the business. So this session is really about the enabling environment, governance policies. And so we have 3 key things to look at. Number 1, the role of governance and the enabling environment in fostering the uptake of DPIs in countries. So we'll have use cases that will come from the panelists, the presenters that will speak to the subject. We encourage you, as we're discussing this issue, to take notes for the Q&A session. And then secondly, we'll be looking at key tools and strategies to really foster the wider uptake of DPIs in health. And then lastly, you hear some case studies in the presentations, and so it's a purpose of this session to unpackage those case studies for wider adoption. Having set the scene, I will be presenting a highlight presentation to just warm up the speakers on WHO's work in this particular space. You just heard me just now welcome Dr. Joyce and the rest of the Kenya team because we had a governance e-health session that focused on the role of governments in the digital transformation of the digital transformation agenda of countries. And so 15 African countries met here, thanks to Helena, Africa CDC, really looking at what governance means in practice. And I'll be asking somebody to help to close the notifications. Melissa, if I may, Melissa, Garrett, Chris, if somebody, okay, thanks a lot. So this is really an illustration of the appetite around regulations and governance in this particular space. And then going back several steps backwards, in 2018, development partners met to agree on principles on digital development and included, amongst other focus areas, the whole issue around strategies to inform transformation. That also includes the focus then on digital public goods. And then fast forwarding, we now have a global digital strategy that has been spoken about at this meeting that is up for renewal next year, which has a vision of enabling everybody to have equitable access to health services. It's really about UHC, and DPIs, as we have discussed, are a key enabler to ensure that we have wider scalability of digital solutions. We have already discussed the 4 pillars, and this session we're really focusing on pillar number 3 of the 4 objectives. So it's capacity building, it is strategies, it's governance, and also focusing on people. And so with these particular 4 objectives, WHO has worked with member states and others to really put in place guidance structures or documents that enable countries to govern the digital transformation agenda, including the National e-health toolkit of ITU. There's an entire chapter on governance. The Digital Implementation Investment Guide, otherwise known as the DIG, really systematizes the call to action in the National e-health toolkit. In the region of the Americas, the Inter-American Bank, working with the American Regional Office for WHO, developed a document on governance of digital health structures. I just want to remind everybody that the 7 building blocks that we all have been discussing remain relevant in terms of strengthening governance of the ecosystem that we're in, particularly this particular diagram that we have socialized as a key framework to inform the implementation of digital health transformation agenda. So in this meeting, we've spent more time on applications and interventions and how DPIs come to play, including architecture. But right at the beginning here, countries indeed are encouraged to inform these interventions by the existence of a strategy. The next session that we'll be discussing after this session will focus on the issue of investments. So to just keep in mind that architecture, applications, including DPIs, really must be informed by a digital roadmap on digital health and an investment roadmap to ensure scalability. So this is a key framework that sort of like puts everything together, and right at the bottom is the enabling environment, including governance there. I just want to recap that at WHO, we are pursuing this journey through the Global Initiative on Digital Health with its 4 pillars, focus on countries, resource mapping, transformation toolbox, and finally convenings like this one to ensure that everybody is aligned. We do have a repository of national digital strategies that we encourage everybody to access. The QR code is right here, so if you would be able to take a moment and take a photo or at least access the QR code. The QR code takes you to the database of national digital strategies, national digital blueprints, and national health policies. So government documents by country are in the database that this QR code points to. We welcome countries that do not have entries in this particular collection. It's an integrated database that is organized by countries and includes relevant documents in those countries. With this scene setting then, and having laid the foundation for the topic, we'll now go into the first conversation, and I'll be inviting the first speaker, Mr. Kiran, to really give us an India use case. The floor is yours. Thank you.
Good afternoon. Hope the food coma hasn't fully set in, and we'll try to wake you up, see if you can learn a few. So over the next 10 minutes, I'm going to try to give you a sense of what India is doing, how does it actually work, and then what's it doing for driving adoption. So India's mission is called, the National Digital Health Mission is called the Ayushman Bharat Digital Mission, which is a bunch of DPIs that India is doing. So one difference from all the diagrams that you're seeing, of course, we have a health exchange, but I want you to notice the word, the consent manager. So a very key thing that India did to align itself with the Data Protection Act. So we'll learn a bit more about how that works. And so it does 3 things. It's definitely supposed to help everybody get personal health records, but it's also going to help data for public health purposes and hopefully also create anonymized data sets. And you'll see a little icon below which says what we have already taken live and what is still being cooked or in the design stage in the Indian construct. So the second big digital public good we have is for between payers and providers. So there's a standardized way by which any healthcare provider can raise a claim for any other health insurance, whether it's public or private, using a common e-claim format as well as a bunch of APIs that allow them to track it from pre-auth to payment. And this is being driven jointly between the National Health Authority and the Insurance Authority in India. And the last one is the one that I don't typically see in the architectures. And apart from data and health data, India has also been looking at how to bring interoperability into digital health services. So there is a protocol which is based on a very interesting open source protocol called Beacon, and our interface is called UHI, and essentially it brings interoperability to things like appointment booking, teleconsultation. So the software being used by the patient and the software being used by the doctor can be completely different, and you can have a way to find the doctor, book an appointment, make a payment, do interoperable teleconsultations, exchange health records, all using that protocol. So I think interesting new set of DPIs that India has built. And the key thing is, like in every other country, apart from these big key DPIs which bring use cases, India also has registries. So the way we identify a patient, in India we call it an Aabha, and this is based on a foundational ID. So you'll see on the top that there's Aadhaar, which is India's foundational national ID database. And the whole system is designed to work for people who have both smartphones and for somebody who doesn't even carry a phone. So you can actually have, for someone who doesn't carry a phone, you can use the foundational card and the biometrics to create an Aabha, and they can actually use that when they visit a hospital. And if you are a smartphone user, you can download a bunch of ecosystem apps that help you create your ID. And the expectation is that you take your ID, and when you go to a hospital, or it could be a public health facility, it could be to a community health worker, you are actually able to share your ID or an Aabha. So we have a very interesting use case where people are able to go to the hospital. There is a QR code that's pasted on the registration desk. They use their PHR app and scan it, and they're instantly registered in the software that is being used by the hospital. So we call that scan and share, and that's one of the mechanisms by which people are sharing. And the expectation we have is that hospitals or anybody who wants to participate in this mission essentially is going to take their software and they're going to upgrade it and become ABDM enabled. So, there's a whole process to get that done. And whenever there is a new health record that they create in their software, the interesting part in India's architecture is they don't share that health record. They simply put a link to the fact that they're holding a health record. So India is using what we call as a federated architecture, and then immediately you get a notification on your PHR app and you're actually able to pull that record. So now, if somebody wants to access a record that's in my medical history, they can, and this can be done by anybody, so it's open. So it could be an insurance provider, it could be a health bot that wants access to my health data. So it also has to use an ABDM-enabled software on its side, and essentially it has to first get consent. So there's a big role that we have for consent, where users are actually doing consents digitally in India using a very standardized electronic consent artifact. And then the actual data, when it transfers, that's where we use FHIR to be able to send the documents in a standardized format. And you will notice that the documents do not go through the health exchange. So it's actually an exchange that happens outside. And so in many ways, this architecture is federated, it's privacy preserving. The government doesn't have access to the personal data, but we are working to make sure that the government can get access to aggregated as well as privacy preserved data streams for its public health management purposes. So that's one of the key differences about this architecture. The whole thing is run by a government agency that's called the National Health Authority. And this is run with an annual budget. So the government gets a budget to run this program, manage all of these DPIs. And then one of the key things is that it's completely open to both the public and the private sector in terms of participation. But like many other countries, I've been seeing that there are digital health acts. Several countries have passed. India has currently taken a position that participation in this program is completely voluntary, both for providers as well as for patients. And that's actually made it far more difficult sometimes to drive adoption. So to help understand what does it take to drive adoption, a little bit of India. So India is very large in terms of number of healthcare providers. We have over 200,000 healthcare providers, about 60 to 70% actually in the private sector, and whole variety of hospitals, diagnostic clinics. And so when we did a survey to figure out what kind of people supply software to them, we found more than 2,000 companies make and sell software to these healthcare providers. So it's a very, very fragmented market. We haven't been able to find even one vendor who has 1% market share. So a very large number of people that we have to kind of deal with. And the challenge is we have to find a way to convince all these guys to modify their software, to integrate with these DPIs. And once they're integrated, we have to get them to go back and deploy it into the hospitals, and that's when you get participation. So it's quite a challenging effort to kind of drive adoption in this ecosystem. So one of the things that I want to share is how are we actually approaching this problem? So the National Health Authority runs something called the ABDM Sandbox. So this is where they have a version of all of these DPIs, which are hosted, all the documentation, how do we integrate and so on. I really want to call out to the Google, the Open Health Stack team, which has actually helped build open source integrators that make it faster. So one of the big challenges we have been having is, we've been talking about this in India. We have a huge number of signups. So you can see about 2143 people who have signed up, but only 253 people who have managed to cross and actually get their integrations out. So people are taking up to 6 months to sometimes a year to get the integration done. And this is one of the core big challenges that we are trying to solve. So the Google effort is really interesting because they released a small open source SDK, and we had a few partners who completed the integration with it in 3 weeks after they started using the SDK. So they reduced the number of APIs that you had to work with from about 40 to 50 to some about 7 or 8. So big difference there. Now, for anybody who wants to cross this integration and come out, the way the National Health Authority has done it is that you have to clear 2 things. All of your applications have to pass a bunch of functional tests, which says, okay, you have done the integration as we expect. Your FHIR bundles are in the formats that we want. And they also have to clear security testing so that we know in our federated architecture that the data is safe wherever they are hosting it. And only then can they get an access to the production APIs. And that's how India's sandbox is designed. Now let's take a quick look at what are the levers that we have for driving adoption? The very first thing, of course, is in a market where it's voluntary for everybody, if we don't have strong use cases that the market wants, you can't get adoption. And this has been a big challenge for us because we so far have just 2 use cases which seem to be getting traction. There are many ideas. As in any brainstorming room, we have thrown a lot of different things at the wall, but so far not much is sticking. And the one use case that's working, and it's only working in public hospitals, is the scan and share use case. The simple reason, people used to go and it used to take them about an hour and a half to 2 hours in the morning to just in the queue to get their name registered before they go see the doctor. Now they're able to walk in with a smartphone scan and then directly go to the doctor. So that's got a hit. And so we have the positive use case. We are seeing some traction for people wanting to, providers, especially big hospitals, which use a lot of insurance, wanting to have a standardized interface to kind of get their claims back. So that's the second thing that's having traction. But outside of this, we haven't had much traction. So we are in the search, and if there are people who have other interesting use cases from other markets, we are really happy to see what could be of interest there. So the second thing that we threw at it is incentives. So currently, the government, in order to encourage participation, is actually paying healthcare providers for every health record that gets linked into this architecture. So they pay rupees 20, but not only are they paying the providers, they're paying the vendor who made the software, the ABDM compliant software, and supplied it to the provider 5 rupees. So we are trying to get both. So our hope is, as more people clear and come out of the sandbox, and they go and sell and say, okay, you can make some money, I can make some money, let's get this going. But in spite of this, private participation has been low. So all the participation we are seeing, almost 95% of the participation is still from public providers. And so finally, we are coming to the last piece that we are hoping to use at some point, which is regulations. And at this point, there are 2 things that the government is looking at. One is, of course, looking at the new data protection bill. So we do think that most of health data and healthcare is going to get covered under the data protection bill. And the way we are trying to promote this is to tell hospitals that if you want to be compliant to the new Data Protection Act, get yourself an ABDM compliant software. So we hope that, and that's the way we are driving it. And so we hope that will drive some more adoption. And then we are also looking at introducing e-prescriptions, especially for classes of drugs which are highly controlled to start with, because that's already well regulated, and as a way to make sure that there is lesser kind of malicious use in that use case. So those are the levers that we so far have. So this is the result so far. We started and launched the mission publicly for people to start integrating in 2022, and we launched the incentive scheme in Jan 2023. So in spite of that, I think it's pretty good that we still have a reasonable amount, but I think the area that's going to really shoot up as things go along is the number of health records and the amount of health records being exchanged. But I'd like to share that in India, we still see this as something in its infancy in spite of all of the big numbers, and a long way to go. Thank you.
Thank you so much. That was Kiran from the National Health Authority. Thanks so much for highlighting key levers. You have highlighted in your presentation the whole issue around equity in terms of the adoption, also regulations, also in the whole issue around incentivizing usage and adoption, plus the whole issue around the interplay of regulations versus the adoption of DPIs, and also the case that you gave us with ADA. Very good. We'll now be moving towards Malaysia from India, and so it's my pleasure to call Dr. Mahesh to give us the Malaysia experience. All yours now.
Right. Thank you, Mr. Chair. Right. So let me bring you to the Malaysian story. I'm sure most of you have heard my friend speak 2 days ago on initiatives within Malaysia. And now I would like to just share with you how Malaysia drove digital adoption through governance and policy levers. And these are lessons from Malaysia's collaborative healthcare transformation. When we look at our vision of digital health transformation, we are pretty new in the field. We've been talking about digital health transformation for years. And it has been a very dismal result where just less than 15% of our facilities digital right now, having EMRs and whatnot. And as Albert Einstein says, in the midst of every crisis lies great opportunity. And I really, really thank COVID for that. It actually brought up and accelerated our digital health adoption. And we have to maintain the momentum at the current moment. So our core mission was to create an equitable, efficient, and high-quality healthcare system through digital innovation, and also aligning Malaysia's healthcare sector transformation agenda. And I would just like to point out three important things here. Number one is to centralize governance, but decentralize implementation. All of us need to be very, very aware to the fact that our players, implementers, are not within the Ministry of Health, but at the level of the district or the state. We have to get them also on board. And we maintain accountability while we empower them locally to ensure consistent standards across regions. We have got about 33 million people living in Malaysia right now, and we need to ensure that equity should be at the core. We need to make sure we bridge healthcare access gaps. We need to focus on all those people who cannot achieve or who cannot obtain this digital health service. In Malaysia, we have lots of villages very deep-seated. We have the Aboriginal community who probably would not even have got a mobile phone. But how now we would want to penetrate all those communities? Remember, we need to make sure that every single patient or every single individual living in Malaysia must achieve whatever a person in the urban community achieve. And not forgetting interoperability, how we need to implement robust standards and enable seamless system communication. And when we took over, or when we started speaking lots about digital health, somewhere in 2023, 2022, of course, during COVID, we ensured every system which wanted to come and play a part or play a role within Ministry of Health Malaysia complies to HL7 FHIR. Now, it's not even a question. All our RFPs, it will be already written there, compliance to HL7 FHIR. And our previous speaker spoke about sandboxes and what. That's also what Malaysia is doing right now. In order for you to be eligible to come and provide digital services within Ministry of Health, you need to ensure that you comply to our standards so we do not eventually have problems later for interoperability. And the role of governance in driving adoption, again, we have this huge platform right now, which is a digital public good, MySejahtera, on how we have now transformed MySejahtera from a COVID-19 app to a public health app. We have now our people who can book appointments at our local health clinics just under 10 seconds, how they can register really quickly, and we managed to bring down lots and lots of waiting time just because of this very quick innovation. And now, what do we do with this digital public good? I like the way our previous speaker put on. We need to start creating stickiness. How do we continuously interact with our patients, right? So when you talk about our strategic priorities, we have three. Number one is regulatory excellence. We need to now adhere to existing acts. I know most of you would ask this question. Do you have a Digital Health Act? No, we don't. Do you plan to have one? Yes, but that will take another 5-6 years. So do I wait till I get my Digital Health Act up to roll out digital health plans? The answer is no. We need to latch upon available acts and regulations. We have a Telemedicine Act drafted in 1997. We have not renewed it yet. We have got our Personal Data Protection Act 2010, now amended in 2024. What I'm trying to say here is this should not be a barrier to your momentum in wanting to do anything within digital health. Second is public-private synergy. Technology co-development, it's so important. I always remind all my colleagues within Ministry of Health Malaysia, we only have two functions. Number one is to govern the healthcare system. Number two is to provide service, healthcare service. We are not a digital ministry to develop softwares. We need to leverage on off-the-shelf softwares. We need to leverage on the market. EMR or digital health for me is a market-driven industry. No point reinventing the wheel. Third is community engagement. We need to make sure that we have user-centered design, continuous feedback on integration. Sorry for this not visually pleasing slide, but this is one which is very close to my heart. For every single thing that we do, we forget the most important piece. It's a puzzle. And the most important puzzle is our patients, the individual themselves. For me, they are the strategic heartbeat of your entire digital health ecosystem. We always talk about us in Ministry of Health, our healthcare providers, EMR vendors, chief information officers, but we always forget to place so much importance on this center, which is the individual. In Malaysia now, we are talking about achieving one citizen, one record. We want to empower every single individual to take charge of their health. We want to make sure after every encounter at any healthcare center, they have at least their summary with them at their fingertips. Moving on to this digital health framework, which we developed for Ministry of Health Malaysia. Number one, we would talk about, again and again, interoperability and global standards. It's so important for us to ensure this. And just now I told all of you that we made sure that anybody who wants to come in and play a role within MOH Malaysia, they have to make sure they adhere to certain standards. And what about old legacy systems? I'm fortunate enough to tell all of you that we should not leave anyone behind. How we can come up with adapters and we can map all those HL7 CDA and whatever HL7 versions, all those old systems, legacy systems are using to connect to our current system. This is extremely important because for you to change any system in any facility, it's going to be a nightmare. Next is for us to look into one of the most important part of governance, policy, and regulation. We always speak about giving incentives, punishing, setting up a new bill to ensure that we achieve lots of adoption. But we took a different approach, not giving a carrot, not giving a stick or using a stick, but we chose a collaborative approach. How do we sit down together with multiple other people and come up together and say that we want to achieve our ultimate goal of being patient-centric and achieving a sustainable digital health ecosystem together? And we just started this in 2024. And you will be surprised. Number one, we empowered our citizens to ensure that they have their health information at their fingertips. Second, we had multiple stakeholder engagements. We sat with all the chief information officers in all different sectors, agencies, from the Ministry of Education, Ministry of Defense, Ministry of Health, and all our private healthcare facilities. And you know what? Our meeting room was full. Everyone showed up. And why? Because they saw the leadership. Here you see my health minister was the one who chaired that meeting. And at that very first meeting, all of them pledged and vouched to start sharing information. The second one is to come up with innovative ways on how we can interoperate, which I think my colleague spoke at large on having the Malaysian Digital Health Certification Network. I know health information exchange is gold standard, but how do you drive adoption? Anyone from Singapore here? Singapore just passed a Health Information Bill 2024. They have a very beautiful health information exchange which onboarded 85% of the healthcare facilities, but only 3% of them started sharing data. So they moved on to your third box where they have passed a Health Information Bill where they mandate everybody to start sharing data. With this new technology or this new modality, thanks to WHO on coming up with this very robust network, Global Digital Health Certification Network, where Malaysia adopted something very similar, and we replicated GDHCN to MDHCN. And you know what? We had our first workshop, and 7 big healthcare facility group actually joined us. And all of them now are saying, yes, let's do this. And we're going to see how fast Malaysia can start ensuring every healthcare facility sharing their records to the patient. And the patient would be eventually the mediator on sharing his or her records between facilities. So these are the lesson learned and key takeaways. Ladies and gentlemen, the success factors. Number one, start with a scalable and modular solution. Do not reinvent the wheel. MySejahtera's success during the pandemic created a foundation for broader digital health adoption. Number two, ensure strong legal frameworks. If you do not have legal frameworks ready, latch on existing ones and create one. Number three, to place patients again at the centerpiece of your digital health policies. Do not forget, those are your clients. The people are the most important part in the entire digital health ecosystem. And of course, besides being punitive, besides incentivizing healthcare facilities, why don't you sit down again and try and see whether we can have a collaborative approach? And I tell you, probably you would find some success. And to be future focused, we need to invest in capacity building. Technology adoption requires human capital investment, especially in underserved areas. Promote global collaboration. Like us in Malaysia, we do not want to create a standard for Malaysia, ICD 11 Malaysia. We want to be globally interoperable. We need to adopt global standards. And lastly, to leverage governance as a tool for aligning our initiatives. Thank you very much.
Thank you so much. Thank you so much from Malaysia for the presentation that really builds on what we heard from India, and we'll be slowly going into Africa with Dr. Joyce. But just to really emphasize the 3 points you started with: equity, which also India spoke about quite a lot, and governance approaches, govern but distribute, and also implementation, and also interoperability. But also you also emphasized a lot on people. So the entire spectrum of people, processes, and also technology. I mean, this is very valid in this conversation. But more importantly, focusing on people and equity. We're now going to go from India to Malaysia. Now, Dr. Joyce, it's my pleasure to invite you. We're making a sharp turn into Africa, to Kenya, the host. So the floor is yours. A big hand for Dr. Joyce as she comes.
Okay. My slides. Oh, okay. Oh, okay. Thank you. So, good afternoon and welcome to Kenya. I'm really happy to see this room full. We have been praying for a successful meeting, and we really appreciate that you took time to come and learn and share your experiences with us. I will be presenting a bit on our experience. I say a bit because our story is more than 3 decades old. And I like to put it out there that a lot of what we are doing, the bravery that we have, the boldness that we have, is because of the many lessons that we have learned. Kenya is a country of 55 million people. We have about 15,000 health facilities, 1-to-1 ratio if you look at public and mission health facilities compared to private health facilities. We are currently attempting to see whether we can now get it right regarding universal health coverage. We are a country that doesn't fear trying and failing and trying and failing, but we think that time is lucky. So this time we are going about it this way, as per this particular slide. A very strong foundation for primary health care, and then with 4 key pillars. And we like to pride ourselves that the pillar that is named health information is the actual game changer pillar. Why? Because for all these other pillars to make decisions, they do require real-time or near real-time data. And we hope to use, and we are working to use technology to be able to enable us have, that particular data, to harness the power of individual level data. Health data portability is a pet topic for our president. He wants to hear that somebody who has traveled to Mombasa does not carry their health records with them, does not have to start explaining their story, what we call in the medical field the history, but rather the healthcare worker on the other end can be able to access the shared health record or the digital health file for that particular patient and be able to continue their care. We are also looking forward to using technology to increase efficiency in healthcare delivery, from simple things like triaging. If you attend one of our public health facilities, one of the biggest pain points is having to get there very early to get a small piece of paper that shows what number you came in. And of course, there are some people who are a bit clever, so they learn the color of manila paper the facility buys, and they come with their own paper. So at some point, we have 3 number 3s. So this is a WHO document that Derek talked about, the global strategy, that gives the requisites for optimization of technology and innovation. And I'll be talking about the legal framework bit, talking about the visioning, which is very important, and talking about the governance. Of course, the other two, we are deeply into them, but allow me to take some time to speak to these 3. So in terms of the legal framework, we have several acts. The Health Act 2017 is where we begin to see the country envisioning that there shall be a comprehensive and integrated health information system. In that particular act, we then see that the cabinet secretary is mandated to do certain things, amongst them come up with e-legislation on things to do with data privacy, for example, things to do with interoperability, and even e-waste is mentioned. We are happy that our Ministry of ICT took up the challenge for data protection, and we have in 2019, in 2019, we got the Data Protection Act. Now, last year, we then saw our president assenting to the Digital Health Act. I've had many people talking about the Digital Health Act. There is no pressure to have this act. But for us, we had reached that time where we required this act. And I'll be talking more about it. We have points of digitization in our Social Health Insurance Act because we call them the UHC laws. So last year, the president assented to 4 laws that really speak to the foundational slide that I talked about, how we are planning, how we are working on implementing universal health coverage so that we achieve it optimally. So Social Health Insurance Act is one of them, and the digital health team wrote the digital health component. So it is in this that we ensured that we indicated that there will be no more manual claims. All claims will be e-claims. There will be self-registration, another pain point that we have been having for a long time when it comes to registering into our, what previously it was called the National Health Insurance Fund. So you can imagine a woman has just given birth, and within a week, you need to visit your nearest NHIF office to register. We actually said no, that people should be able to do self-registration, and we're seeing a lot of that now. And then we have the draft digital health regulations, which we are currently doing public participation on them. We definitely have very many policies, strategies, and guidelines, because good law is actually made when you have a lot of these documents and a lot of lessons learned so that you put in exactly what is required in that law. So this is our Digital Health Act. The components are as shown. And the key things are, this act establishes the Digital Health Agency. I heard in India that there is an institution, government institution called the National Health Authority. So that is ours now. It's called the Digital Health Agency. And it's a regulatory agency and also an implementing agency. When we came up with this, it was after the realization and the appreciation of the kind of work that is required for a digital health transformation. And we had to come to that point where we said that as Ministry of Health, we cannot meet what Kenyans expect of us. So for us to deliver digital health transformation, we need an agency that purely does that kind of work. The other thing is that the agency has increased the trust currency, which is the one key thing that has to be on the table, because if people don't use your systems, you may as well just close shop and go. The Digital Health Act also brings in now the whole concept of the comprehensive and integrated health information system, and the agency is the administrator of that system. The agency is also the custodian of all health data. The Act further goes ahead to say that the Ministry of Health shall ensure that there is a health data governance framework, because we realize, and we had already been seeing the need for this long even before the Act. Actually, the data governance framework came a few months before the Act because of the many things that we were going through when it came to health data. And then confidentiality, security is obviously the biggest component in our Act, because people fear their health data being known out there compared to their financial data, for example. And then, of course, we have things to do with applications and the e-waste, and then health tourism, which is also very big. So we want our patients, when they're going to India, because India is one of the countries that really gets a lot of Kenyans, that they don't go with paper records, that their digital health record is actually moved to the doctor in India, and when the patient comes back, the doctor in Kenya is able to know what happened while in India. So these are our regulations. So as I mentioned, we have just started our public participation actually this week on Monday, and it sounds like this week on yesterday, and we have 3 of them. One of them is on the health information exchange, basically talking about our data, our digital public infrastructure, the registries, how they are going to be run, everything that needs to be known about the registries from a regulations point of view is there. Then we have one on the applications. So recall I mentioned that the agency has a regulatory function. So the regulations for the applications comes together with a certification framework that provides the standards for what we expect a digital health solution in Kenya to look like, so that it is then able to interact with the health information exchange, and the Digital Health Agency will ensure that the certification mechanism is set up, and we are going to work with our various partners, academia included, to see how that can be done. And then we have, obviously, the biggest piece of regulation is on the health data management. So those 3 regulations, we are hoping that by early next year will be published. So that is on the legal framework. On the visioning, everyone in digital health in Kenya knows this slide. We call it the famous digital health superhighway slide. Because if people are not working together with you, then you're just implementing your own things. So the slide is one that we have consistently exposed to our digital health stakeholders, so that they understand where we are going as a country, and they ask themselves, how can I plug into this? So the center 2 rectangles are what really talks about the DPI, the registries that we are working on. So currently the client registry, for example, is up and running, because it is through that we are doing our social health insurance registration. We have over 15 million, slightly over 15 million people who have registered through various forms, but the biggest channel that we are using is the one up there called the patient portal. It's called Afya Yangu, meaning my health in Kiswahili. And the first use case for that particular patient portal is the registration into the social health insurance. We are also looking at the facilities right now. About 8,000, slightly above 8,000 facilities have enrolled and are using the provider portal, which is also digitized, so that the claims can come in as e-claims, even as we now work on the next piece of work of ensuring that at least our public and health and mission hospitals are digitized. Today, 1 in 3 health facilities in Kenya has some form of digitization, but when you come here in the next 2 years, we will be reporting at least 80% of our health facilities, all health facilities, because we expect the private health facilities to also follow suit, will be digitized end to end. The shared health record, we are going to start seeing it coming into action in the next year, but we've already defined what needs to be there. The terminology services are up, and we are currently now working on ensuring that the health facilities get digitized. So we are working with the various ministries on issues to do with power and internet. Then on governance, we have several documents. We have the data governance, health data governance framework, and the Kenya Health Enterprise Architecture that really just breaks down the issues, I mean, the blueprint of our digital health. And these documents have gone hand in hand with the regulations. We expected to have done the regulations and published them sometime this year. But now that they'll probably be published next year, our documents will just change the date because we've been updating them as we've been doing the regulations. But they are very core, and they are some of the documents that people have already been using even before they are actually endorsed by our cabinet secretary. So in terms of reflections, so we like to talk about standards a lot. But it's only when you now start implementing that you realize it's easier said than done. So we have come up as a team, and we want to now formalize it. You know, the role of the community of practice. We have a digital health technical working group, but we want to empower it because it is there that we should be discussing what standards should a country adopt. Because any standards that we are adopting have some implications somehow, even financial. So when we adopt certain standards, we don't want private health facilities asking, why did you go this way? And yet, you know, like maybe there's another fire other than the fire that we are talking about. So we want every stakeholder to feel part and parcel of that decision making towards adoption. So one of the things is, yes, we have been having a semblance of how we get to adopt these standards, but now learning from one of the biggest deployments that we've had in the past within the HIV program, there is a very big role for a formal way of adopting standards as a country. When it comes to the testing, and this even came up yesterday, as I told you, we are doing public participation on our regulations. So there is testing in the lab in a perfect world, and then there is testing out there. So when we said that the Digital Health Agency will be doing certification and doing all the testing, we are testing in a perfect world. But perhaps when that solution goes out to the imperfect world, will it be able to work? So we are also now starting asking ourselves, are there sandboxes for imperfect world? Or do we just call the piloting phase the sandbox for that particular moment? Then innovation. So we will have the sandboxes for actual, work, but also we want to encourage our young people to be as innovative as possible. So we are collaborating with various universities in our country to be able to have sandboxes at that level for the young people to go and test out their solutions before now they come to the DHA. On incentives versus innovation, it was interesting to hear India presenting that they are paying people to do the uploading of the record. So for us, we don't quite I mean, for the longest time, the last time we saw any incentives as when it comes to health data was when the HIV program was starting. At least those days we used to pay people for their numbers in, let's say, HIV testing. But as a culture in our country, we have, and which we hope to continue, the incentives should come out in a different way, and that is what we are trying to bring to the table. So to the private sector, for example, when we are discussing the health information exchange, we show them why it's important for them. Yes, it's in the law, but we also don't want them to feel like it's coercion. We want them to appreciate that if they join the health information exchange, that they have the capability of also increasing their business, increasing the number of clients that come to them. Even the health insurance providers. Yes, we have the national one, that is the Social Health Authority, but our health insurance providers are actually the ones, once they understood the vision, they were like, yes, we want to be part of this, because they saw why they should be part. The win-win bit is what I would term as incentive. But actual money, you don't quite see it. And then where do you draw the line between incentive versus innovation? You know, we want people to embrace innovation because it's a good thing, and not because of actual incentives. But as I've explained, we do show incentives via the win-win scenarios. So in conclusion, we always like to say we do this for these three things because the patient is the center of all this action. We want to ensure that we have improved the data quality so that we can improve their clinical experience, so that we can improve how they are managed, so we improve the various policies that we have in terms of management. And broadly, from a public health perspective, we improve how things are running in the health sector. In conclusion, now the last conclusion, all this cannot happen without extreme political will. If I had just summarized whatever I've said, it would have been, if you have extreme political will, and for us, we have it from the highest point, our president, this is his pet project, this is his pet topic. We have been able to do all this because of that. A few weeks ago, October 1st, was the date we were all holding our breath in Kenya, because that's the last date he said. He said we are not pushing it again. We were to start on 1st July. We went and told him we are not ready. Then he asked us, how many months do you need? We said 3 months. We thought we'd be ready 3 months, at least to just do 2 components, to register people into the social health insurance and to ensure that our facilities can do e-claims. 1st October, all of us were holding our breath, at least the people who are implementing. And we thought we could get some more time. But he said, no, we move. We continue as we learn. And I think for me, that is a fatherly kind of thing that we needed, because sometimes you may be focusing so much on the perfection and you forget the progress. So we are where we are, and in 2 years' time, we will even be further because of the extreme political will and the understanding right from our president of what digital health transformation is, what it involves, and the appreciation that once it's up and running, that the Kenyan will be the winner. Thank you very much.
Asante, asante. Just to thank you, Dr. Joyce, for talking about UHC regulations and also the infrastructure that you have. In conclusion as well, we have Nat that is going to take us now to the global perspectives, and looking forward to listening.
Thanks, and I know we're a bit behind on time, so I'll try to be quick. I think all 3 of my fellow panelists have clearly showed the importance of leadership and governance overall, especially within the healthcare sector. But I also did want to take this opportunity to highlight one critical aspect that we haven't really touched upon in these past 3 days, is the concept and the problem of cybersecurity, because this is a key DPI that we need to consider that is requiring whole of government governance and collaboration. So I think just quickly, there's increasing threat of cybersecurity across all health sectors, and it's been increasing every year. As you'll see, eventually it comes back up again, I guess. But I mean, I think the other thing too that we've noticed is that countries haven't been ready for this. Within, I think the last couple weeks ago, there was only a recent request for support from WHO to provide a statement to the Security Council regarding cybersecurity within health specifically. And that's simply because health in particular is such a vulnerable sector with so much data, so much valuable data. And because of the fractured digital health system, which is why we're all here today, there's clearly a gap which people have been leveraging to be able to essentially hack into the systems. And I think it's important to understand too that cybersecurity attacks don't just happen in a silo. There's all these different factors that come into it. Of course, the technology piece is critical. You need to have your systems in place, but it's not something we can just delegate to the developers to make sure that they can handle it. Because people also are the weakest link within any system, so ensuring that people are adequately trained to be aware of what these potential gaps and threats are critical. And then, of course, the other thing that we don't like to often talk about is the geopolitics of all these things, because cyber attacks are, to put it simply, a form of warfare, and they are using attacks on healthcare as a way to be able to leverage that. So I know we're talking a lot within the health sector of collaborating with our colleagues in the Ministry of ICT, and of course that's extremely critical. But I think depending on the country context and depending on the geopolitics of your country, you might also have to consider actually working with your departments of defense as well, because this is a key gap and vulnerability that people are leveraging. And so when it comes to governance specifically, people always ask, well, whose responsibility is it actually? Because within cybersecurity, it is really a shared responsibility, but if everyone's responsible, then no one's responsible. And so we've seen many countries have different ways of governing this. So sometimes people will have a dedicated chief security information officer within the health sector responsible for all health data, that they work closely with other health sectors. Sometimes there's a dedicated agency that then has a dedicated focal point that focuses on health, but they also are reporting to the same individual across all sectors. And I think at the end of the day, this really is, again, what works best for the country. But what's critical is that there needs to be someone accountable within the health sector for health data to ensure that there are secure systems, there are standards in place, and there is guidance for developers to be able to do this. And they have to work closely with their counterparts, because similar to disease areas, cybersecurity threats know no borders. They also know no borders when it comes to sectors. So an attack that you see within the healthcare system could easily be applied and be seen in other systems, in finance, in agriculture, and education as well. And so just some key takeaways is that really it is a shared responsibility, but there has to be accountability within health. This is something that we do need to take a whole of government approach. And it's not just about securing your existing systems, but actually ensuring that there is resilient systems in place, because it's never a question of if, but a matter of when. And I know we probably haven't really discussed it here, but I can imagine there's definitely been, and we've heard of many instances of cyber attacks within healthcare systems and EMRs around the world in all settings, so high and low income countries alike. And so ensuring that there's a cyber aware workforce is also really critical, because again, the weakest link is the individual. So ensuring even people who are cleaning the health facility are aware of privacy protection practices are really critical, as well as health workers, patients, and everyone who's managing information regards to health. And then of course the legal frameworks, which I think all these colleagues have already covered, are really critical to ensure that those frameworks are in place, to ensure compliance. And yeah. I think I will leave it there. Was that quick enough, Derek? Oh, just one last thing is that WHO is developing guidance on this. We've recently published a meeting report in which we held last year around this conversation specifically, but we do have 2 guidance documents coming out contextualizing the existing guidance on cybersecurity for the health sector. So I think that is definitely it, yes.
Thank you so much. Thank you so much to the exceptional panelists. We heard from India, Malaysia, Kenya, and lastly from the WHO. We would have loved to have an interaction, and hence that slide. But given the shortage of time, we're going to take this as an intro to the topics. Do reach out to the different speakers, make networks, continue the conversation of the wonderful work that they have illustrated on the panel that was looking at policies and regulations that enable the wide adoption of DPIs for health. Thank you so much. I've been your facilitator, Derek Mullen from WHO. Looking forward to the offline conversations with the panelists. And it's now my pleasure to hand over the stage to the next moderation. Thank you so much.